right, good morning, everyone. We will go ahead and get started. So thanks for joining today's monthly PO call. Here's our agenda that we're going to be going over today. We're going to talk about the collaborative wide meeting registration and agenda, just a few wrap-up items from the spring regional meetings, go over some end of the year VBR reminders as we're in those last 2 months before everything is due. And then want to talk to you about some performance measure updates, both on a reporting schedule on the A1C performance measure, and then introducing our thoughts on our next performance measure and sharing some opportunities for you to give some feedback on that. So first, every PO should have their PO clinical champion and PO administrative lead attending the collaborative wide meeting as per the requirements in the PO scorecard. Please make sure that you register by today if you haven't. Oh, sorry, that should say May 12th. Portal registration is available. So if you are on portal.mct2d.com or .org, you'll see that along the left-hand sidebar with the opportunity to register there. We're going to be hosting the meeting on Thursday, June 5th in Lansing at Meeting Space. The meeting is going to be from 10 a.m. to 3 p.m. this year. And this is a little bit of the agenda. You'll also be able to see this on the registration page and download it as well. So we'll be beginning with an overview and updates from our program directors. We're then going to be spending the next hour going over the performance measure that we'll be wrapping up around A1C control. We'll have an hour for just lunch and networking and a little bit of a break for everyone. Then we're going to come back and be discussing our future performance measure, including a panel from the POs there. And then colleagues from MShield will be joining us, which is the collaborative that supports social determinants of health and addressing health equity, to talk about race and ethnicity data that will be incorporated into our dashboards by the third quarter of this year. So lots of exciting updates for us at the collaborative meeting, and we're really looking forward to having you all there. And we're also hoping this works out a little bit easier administratively for everyone. I know initially there was the wanting to have those in conjunction with Inhale, but I think it made for quite a long day, everyone, last year when we did them both together. So, and also ended out with people in some rush hour traffic with the meeting ending at 5. So hopefully this midday meeting and these separate meetings remove a little bit of this burden and make it a little easier on everyone to attend. So looking forward to seeing you all there. For the regional meetings, we wrapped these up last week. Our final regional meetings took place last Thursday. By the end of this week, all of the attendance will be updated on the admin portal. So since we just wrapped up those meetings and have been traveling back, just give us a little bit of time this week to get everyone updated on there. And if by the end of the week, please notify us if you think that someone has attended a meeting but hasn't been marked as such, and we'll investigate what happened there and try to get that corrected. And then for those who were unable to attend the meeting live, we'll plan to distribute the recording of the meeting by the end of the week as well, along with those quiz questions, so that those who weren't able to attend can make up their attendance. So please note that missing the meeting still does result in a regional meeting strike. That's where we allow practices to miss up to 3 in-person meetings over their participation in MCT2D. But viewing the video and completing the quiz will make sure that the practice earns the VBR points associated with the regional meeting measure. And then practices will have until July 1st to review that recording and take the quiz. There was a question in the chat. Is there a way to see who is registered for the spring collaborative meeting? We don't have that on the portal like we did for the regional meetings, since it's just at the PO level. But what we can do is at the end of the week, we can run an audit for each PO and make sure that the clinical champion and an administrative person is registered. And if they haven't, we'll reach out to the primary contacts at the PO and let you know that there's still some registrations pending. And then just as a reminder, all of the PCP VBR requirements are due on July 1st. So this is, as many of you may know, an extension from last year's. Blue Cross Blue Shield doesn't need the numbers until July now, so we're able to give everyone a little bit more time on completing those requirements. So as you can see along the right-hand side, there are a lot of these still pending, especially at the physician level. And everything due on July 1st includes the PO level learning community requirement, the physician level, and the practice level, as well as the 5 A1C forms for any practices who were meeting the performance measure at the beginning of the year. For the learning community requirements, reminders will be sent to you as we get closer to the deadline, letting you know which practices and physicians still need to complete those requirements so that you can do follow-up with them. For the physician level one, we email both you and the clinical champion at the practice. And then for the practice level, we email the POs and the clinical champion, letting them know that their practices still haven't met this. And for the A1C forms, the way that you check that as well is in the admin portal 2. Along the left-hand side, there's a bar that says A1C forms, and that shows you who has completed it and who hasn't. And since this question has come up in the past, I just want to reiterate. So for any practice in an aggregated group, so those are the practices that had less than 100 patients at baseline, and have been put into a larger group with other practices who weren't at that 100 requirement, they only need to submit 5 total. So if you have 5 practices in that aggregated group and they each all submit one A1C form, it's met. If one of those practices submit 5 A1C forms, it's met. So as long as across that aggregate group we get 5, it's not 5 per individual practice, it's 5 per aggregate group. And there was a question in the chat. If a practice hits the minimum 80 points for VBR and hasn't completed the physician learning level requirement, did they meet the VBR requirement? So yes, as long as that minimum 80-point threshold is met, if they don't meet the other ones, that's okay. So for the physician level requirement in particular, I think we have multiple tiers on that one where, you know, if 50% of the practices meet it or physicians have done it, you get partial points. If 75% have done it, you get even more points. If all of them have done it, you have the full points. But yes, if the practice is meeting that VBR threshold, even without that being fully complete by every physician, they will still earn the VBR. Thanks for that question. I do think that's good to clarify because this is the first year that we've added in that point system. Any other questions on the VBR? Okay, and just to some refreshers, and we'll send this out right after the meeting or after the meeting so that you have like these individual links easily accessible. These are all of the ways upcoming that people can meet the physician level VBR. So we have 2 more live learning community events, one on this Friday, May 16th, around insulin and type 2 diabetes. Another one on June 13th, our second one in our diabetes complication series on liver disease and retinopathy. And those ones offer CME. If your physicians are unable to attend them live because that 12 to 1 lunch hour doesn't work for them, they can watch the previous recorded ones, any of them, and complete a quiz about those to get that. So they can do that completely on their own time. They can also participate in the CGM user experience program. And then I know a lot of you are saying that your physicians are strapped for time and I don't really have a lot of time to dedicate to this, maybe not even enough to watch like an hour-long meeting. There's always the option to give feedback on a physician-focused tool or on the coverage checker, which I know are 2 things that the collaborative uses a lot. Those should each take less than 5 minutes to do and should be really quick. So if you have physicians who aren't feeling like they have a lot of available time, those would be the couple options I would direct them towards. Then for the practice level VBR, we again have multiple options to meet this too. So giving feedback on a patient-focused tool, though I do want to note, the feedback on these patient tools is meant to be like from a patient. It should be from a patient that you've given this tool to. When they come back in the office, you say, hey, how did you like this? Was this helpful? Or even when you give it to them. That's why this is a practice level VBR option instead of a physician level VBR, because we understand that it's going to take additional effort to kind of collaborate with the patient to get this feedback. We don't feel like this has been used as intended, so we may remove this option from the VBR in the future, but really ask that you try to make sure that a patient is the one like giving that input. And yes, we will be sending out these slides to everyone so that you will have all these links easily accessible in response to the question in the chat. Other ways of meeting this, you know, we have a couple of these are already have all the signups for it, but participating in the low carb workshop does it. That's currently taking place. We had the first session this morning. that will also meet the physician level requirement if it's a physician who's participating, submitting a dot phrase to our dot phrase library, accessing the MCTTD patient data dashboards twice during the performance year. So this does require that they have the permissions to be able to access that. If you have physicians or someone at the practice, maybe an office manager who needs to get access to the dashboards, just send us an email. We'll help you get them access, but signing into that and using that data will count towards the requirement. Participating in the user experience session. So we have ones on the admin portal. There's a few slots left for the June 4th date. And then we also have a pre-diabetes focus group on May 30th that has a couple slots open for it. But probably most helpful to all of you and to most of the practices who still have this pending, we have in the past around this time of year typically distributed a survey that gets us some questions that would be helpful to us as a collaborative as we plan our next steps around what would be helpful to the practices, what support they need, how they're currently doing things. So it tends to be kind of a medley of questions related to different topics that just help us determine future directions. We're planning on doing one of those again. So by the end of this week, or maybe very early next week, if we end up getting delayed for any reason, we'll be distributing a brief survey to all of the practices. It'll take about 10 minutes to complete, and doing that survey will also meet the practice level learning community requirement. So I anticipate a lot of those that still haven't met it, that will be a pretty easy and accessible way for them to get that met. So we'll get that out to you all shortly. And finally, wanted to touch on the performance measures. So our current performance measure that we're in around A1C. So just as a reminder to everyone, we distributed PO reports on April 21st. Those are available on the admin portal under PO quarterly reports. Those had data through 1/30/2025. And then we'll be sending another update in July with the final results for the performance year that'll have data through the end of April. I do want to note, though, I know we've gotten some questions about this. Even if your practice is currently meeting the measure as of like the interim reports that you've received throughout the year, the A1C measure on the practice scorecards and the PO scorecards will not be shown as met until those final reports in July. Even if the A1C forms have been submitted, even if the practice has been meeting it throughout the year, because we're looking at those final scores to say whether it has been met or not. So please don't worry if your practices are doing really well on this, they've got all their forms and it's still not showing up as met. It's just because we were waiting till the final reports until we change that. Okay, so now I wanted to take some time to introduce you to our next performance measure that we're going to be launching and provide you some details on it. There's going to be more to come on this, and I do want to note it is still pending like a final sign off and approval from Blue Cross Blue Shield, though we've been talking with them throughout this measure and they're supportive of it, so I don't anticipate any issues there, but did want to give that caveat. So we are thinking about another measure related to HEDIS, and the rationale behind that is it is the data that we tend to have the easiest access to, since most of the data that's submitted for PPQC and QMI relate to meeting the HEDIS metrics. We can get a lot of this information from the claims data. And then additionally, we also want to think about burnout for you and for your practices and the numerous different quality programs that you're asked to work on. So aligning measures instead of pulling you in more directions kind of feels like the right way to go. So the kidney health evaluation measure, looks at the percentage of members ages 18 to 85 with diabetes who receive a kidney health evaluation, which is both an eGFR and a UACR during the measurement year. So we've included on here the 95th percentiles for that, 64.65% for commercial, and estimated 62% for Medicare. Now, we're planning something related to this for our measure. I do want to tell you some details and where it differs. So first, we're not going to be looking at eGFR. As far as this, we're going to be looking solely at urine albumin creatinine ratio testing and whether or not that test was complete, not on the result of the test. So additionally, while we've added all payer data to the registry via ACRES, when we do this as a measure, we're still going to be limiting it to the Blue Cross population because most of this data is coming in via claims. So we do have some clinical UACR records, but if we measured it at that, it would disadvantage your patients or your practices because not a lot of that information is coming through those clinical records. In addition, while this is looking annually for the HEDIS measure, we're going to be using a 14-month time frame because we want to make sure that we are accounting for patients who weren't seen exactly within a calendar year. Again, we want to give your practices that grace of like, okay, this was a week outside of a year time frame, but that was when we were able to get this patient is we don't want to like ding practices for that. So we're going to be extending that time frame a little bit there. Additionally, we're going to be measuring this at the practice level and not do aggregate groups. So this will also be how we do the A1C measure going forward as well. We thought the aggregate groups would be helpful just in practices not having a very small patient count to base this off of. And I do still think that is a benefit to them, but I think this was a little more confusing than it was helpful, and it kind of gives the practice more locus of control because in that aggregate group, really each practice is only kind of able to change things within their own practice. So we wanted to be able to recognize that autonomy and let them kind of work on their own improvement versus being grouped with other practices. Though that does, like I said, lead to some low attributed patient populations. The smallest practice was 12. The practice with the most attributed patients goes up to almost 3,000 there. And then just as a note, we're going to be aligning in a way with the nephrology practices within MCTTD. They're also focusing on working on a UACR testing measure as their performance measure as well, with the same time frame that we're going to be using for the PCP populations, though their target rates and the way they're structuring it is going to be a little bit different. So this is how practices within MCT2D are performing on this measure currently over that 14-month time frame. We have a huge range in performance where some practices are having 10% of their patients getting an annual test, all the way up to practices having 94% of their patients getting that test. And then our median is above the HEDIS percentile, 95th percentile, which is great, and a testament to how great that your practices are doing and how much they're focused on quality diabetes care, where we're looking at a mean of 74.45%. So getting into the details of this measure and how we're planning to do it. So we're going to align like with that HEDIS age range of 18 to 85. Like I mentioned, we're going to be limiting it to patients that are Blue Cross Blue Shield attributed. Another reason for that outside of the claims piece is because using ACRES attribution, ACRES attribution can be up to 3 years, whereas Blue Cross is limited to a year. Again, we don't want patients that aren't actually being seen like by your practices to be included in this. And again, the claims data isn't very well populated. And then any patient that we have at least one claim for any service, not a UACR, over the past 14 months, making sure that we are receiving claims data for that patient. And as far as the target rate, we're asking each practice to achieve a 10% absolute improvement on their baseline rate. So the example here is if a practice's baseline rate was 54.5% of patients, what their goal rate is going to be is 64.5%, and that is up to a rate of 90. So any practice who at their baseline is at 90% or above, they're just going to be asked to maintain that rate. And we are going to ask those practices to give like a presentation at the MCT2 fall regional meetings to kind of share their approach and how they've been able to be so successful in that. And again, as follows from this too, since the rate is up to 90%, if you have a practice that's at 87% at a baseline, we're not asking them to get to 97%. We're just asking them to make that way up to 90. So any practice between 80 and 90% is going to have a less than 10% target improvement. The baseline rate we're looking at for this is January 1st, 2024 to February 28th, 2025. So we did a 14-month baseline period as well. Our team is currently working on developing those practice-specific baseline reports since we do have that data as of our most recent data refresh through February 28th. And we're going to be distributing these to you sometime this month. And then the measurement period for this is going to begin July 1st, 2025 and go through August 30th, 2026. So again, a 14-month period like for that measurement year. We've already gone over that, so I'm going to skip that, and we covered that as well. And the same thing, we're going to be keeping the same weighting for the measures that we've done in the past. We're going to do 3% participation. So that will be those same participation measures as our current VBR year, going to be the regional meeting attendance in person in spring and virtually in fall, the physician practice and PO level learning community requirements, and performance will be split for the performance measure based on a maintenance A1C measure and a proposed UACR measure. So I need you to bear with me on this next slide because it is a little bit complicated, but I will walk through what this looks like. So you may have noted that the measurement timeframe ends in August 2026, like we said, which that means that we are not going to be able to have that data like sent to Blue Cross in time for them to begin paying out on that measure beginning on 9/1/2026. So what we're going to be doing is paying out on the A1C measure again. So basically, while your practices are going to be working on the UACR measure beginning in July and making those changes in their practice, working on that through August 2026, there's going to be like a year between when they finish that measure and when they're paid out on it. And so much like this year, when the payment beginning in September is going to be based on their A1C performance for this year, basically doing the exact same thing for another year where it's just going to be that A1C measure that they're measured out and paid out on for 9/1/2026. And then in 9/1/2027 is when they'll be paid both on A1C performance and the UACR performance. And I'm going to pause because there's a question in the chat. But if a practice hits the minimum 80% points, they don't need to hit all components for the 3% measure. Yes, that is correct. If they hit the threshold, it doesn't need to be that they exactly did every single thing of those. It just needs to be that the things that they did do equal up to that 3%. So like we talked about earlier, if there's a few physicians in a practice who don't complete the physician level learning community requirement, they're going to lose some points on that. But as long as they hit that threshold, they'll still be able to earn the 3%. Yep. So what this will look like for, again, we're looking way ahead, that September 1st, 2027 payout. We've kind of split these measures and weighted them. And again, like I said, I know this looks very complicated. We have the UACR measure weighted higher at being over 60% of like this score. And then the A1C measure being weighted at 40%. That's because we would consider this more maintenance at that point, where we'll have been working on it for 3 years, plus your practices have been performing very well on it, even beginning in this initial year. And then kind of just like that example I was giving with a physician level VBR, we have those different tiers where if 0 to 25% did it, you get X amount of points. If 26% to 50 did it, you get more, etc. We've kind of tiered this that way as well. And again, this is to make this more achievable for your practices. This may look complicated, but that's because we didn't want to say you have to meet both of these and do perfect on both of these, or else you're not earning that 2%. And unfortunately, we aren't able to split that 2% VBR into 1% A1C and 1% UACR. The way that Blue Cross Blue Shield does it is it's 3% and 2%, and that's it. And you can kind of make it work within that. So we've split this a couple ways where for A1C, we do have that split between commercial and Medicare still. So meeting those 95th percentiles for both is 100%. Meeting one and improving one will be 75%, met one and not the other is 50%, and didn't meet either is 0%. So as this implies, let's say a practice met one and got 50%, that means they're going to get 20% of these 40 points. Like we were talking about with those threshold scores, it's the same thing. 80% threshold score is what's needed to earn the 2% VBR associated with performance. And then here too with the UACR, like I said, the goal rate is a 10% improvement, but we're going to be giving partial points based on, these other scores. So to give you an exact scenario, let's say one of your practices improved 7.5% on their UACR measure and met one of the two for HEDIS. Let's say they met the Medicare rate, but they didn't meet it for commercial. They'll get 20% here, and then they won't be able to meet the measure because they won't have received the full amount of points to be able to hit that 80%. But if they met one and improved one and got this rate, they'd hit that 80%. So we'll be able to help you like with these calculations and things as they're coming out. But really, the reason that we kind of divvied these up into multiple different ways is so that your practices have some room for error and still be able to earn that 2% VBR. So we are, much like we did before with the A1C measures when we launched them, we want to give you an opportunity to share any feedback, concerns, thoughts about the measure, things that we should be considering, ways that your practices may need support. Again, I'm going to send this out at the end, but here is like a Calendly sign up. If you do want to set aside some time to talk with us, these aren't mandatory in any sense, but if you have concerns about this with your practices, if you want to talk through like your specific scenario and how you've been approaching this and how we can support you, please feel free to set up some time with us. We want to hear your thoughts on this and be able to support you and take these things into account. Um, and as I mentioned, we'll be talking about this as well at the June 5th collaborative wide meeting. We have an hour of the meeting dedicated to talking about this. Some of the questions that we're including at that practice level survey that I mentioned earlier that will meet the practice level learning community requirement is going to be around like practices, current processes and procedures around UACR. We'll be able to share that and kind of give a look at how the collaborative is approaching it at our collaborative wide meeting. So we plan and want to support you in your practices in this. And so we know that having these discussions will be a helpful starting point. That said, any questions about what I've shared so far or any concerns, comments, thoughts? Mhm. Okay. Well, like I said, please feel free to sign up for a meeting if you have more to share one-on-one, and we'll be happy to talk through that with you. And then the last thing I had was just this final reminder about our next learning community event coming up this Friday. I know we've talked a lot about the newer SGLT2s and GLP-1s, but there are some patients who still are using insulin in the practices at the fall regional meetings when suggesting topics, wanted to hear more about like how using insulin in type 2 diabetes and things that they should know and keep in mind. So two of our endocrinologists, Kara Mizukami Scout and Jenny Iyengar, are going to be presenting on this Friday, and it should be a really helpful, great learning community event. Right. And that is all that we had for you today. We ended right on time. So we'll get these slides sent out to everyone so that you have those links easily accessible for the learning community events and the other ways to meet the VBR requirements. And hope that you all have a nice rest of your day. Thanks, everybody. Mhm.